Hello, I'm Sandeep Sahay and I'm a pulmonary hypertension specialist at Houston Methodist Hospital. I work at one of the pulmonary hypertension comprehensive care centers at Houston Methodist. Basically, we treat patients with all types of pulmonary hypertension. Today, I would like to talk to you about clinical trials and why they are important. If you look at the history of pulmonary hypertension, if we go back to early 90s, late 80s era, we really didn't have any medication for treatment of pulmonary hypertension. The only option for these patients used to be getting them transplanted. And at that time, in early 90s, transplant also was a pretty naive thing. So in the last 2 to 3 decades, we have definitely evolved. We have known so much about pulmonary hypertension. We have got so many more medications, but it's still not much. I mean, if you compare it with any other commonly seen diseases, we say that the PAH is still rare. Yes, it is still rare. But I feel it's still under-recognized because in community, half the time when patients present with these vague shortness of breath symptoms, community physicians, they start with obviously common things are common. So the evaluation starts with the common things and then kind of some people are able to get to the right place and right physician and some are not. So early recognition and all that thing is very important. Coming to the clinical research, that why that plays a big role. So I was saying this, that if you compare it in the last 2 3 decades, that from one or no medications, we have currently 14 FDA approved medications in the United States. Now, what these medications have done, they have definitely improved the survival. I mean, a disease which is still considered as a median survival of 2.5 to 3 years, but now we are seeing patients living over 10 years, 15 years, some of them are even 20 years. So there is definitely improved survival with the medication. So that's where the importance of clinical research comes, because we are noticing that we have definitely improved survival, number one, with these new medications. Number two, we have noticed that their quality of life has also improved. So it's not only about living longer, but it's about having a better quality of life also. That's what we want for our patients. We want for these young people who are struggling with a disease which by nature is progressive and it is going to progress. So with these medications, we are able to give them hope. And if you look at all these medications, they are basically a result of clinical research. We first identified different pathways with which we can attack this disease. And then with those pathways, we are now helping these patients basically. And now if you look at the newer research which are coming in last 2 3 years, currently we have mainly 3 different pathway medications with which we treat these patients. But now we are looking for more pathways. Maybe we can try something else because still there is a room to improve. I mean, we can definitely look for some other pathways. Many clinicians, researchers across the country or world, they are looking for different alternative pathways, more medications so that we can treat these patients. We have a bunch of medications for diseases like COPD, asthma, pneumonia. We have infectious diseases. We have thousands of different antibiotics. I mean, if patient doesn't tolerate one medication, you switch him to another antibiotic. You always have an alternative. But that's not the case with PH medications. If your patients do not tolerate one medication, you have to really think hard to find a good alternative agent for your patient because you just have those 12, 13 medications to play around. And so sometimes that becomes challenging. So that's another area that you want newer medications, you want clinicians, researchers, industries interest in developing new medications or new pathways. My particular research, if you look at this CHEST Foundation grant, which I got, is basically to identify a role of estrogen as a culprit pathway in development of pulmonary hypertension. So the whole concept came from what we have noticed in the last roughly 10 years. There is a lot of basic translational and clinical research which has been done to find out if there is some abnormality in estrogen pathway, which leads to development of pulmonary hypertension. Just to simplify things, we say that pulmonary hypertension is more common in women. If that has something to do with their higher estrogen level, we don't know as yet, but that's where the whole idea started. Then one of the very nicely done research study by Dr. Eric Austin at Vanderbilt, which showed that they basically had patients with familial pulmonary arterial hypertension, and those familial patients, some were mutation carriers, BMPR2 mutation, and some were basically who had disease. So what they compared in that, like those who developed disease, they actually had a higher level of urine metabolite of estrogen, which is 16-hydroxyestrone, which is actually considered a mitogenic. It leads to mitogenic changes or angioproliferative. What that means is it leads to blood vessel proliferation, which makes pulmonary arteries thickened and stiff. The higher level of this estrogen metabolite was seen in these patients who develop pulmonary hypertension with this BMPR2 homozygous mutation. So that's where things came to light that maybe estrogen plays some role. So what we are trying to do, we are trying to enroll, and I just enrolled my first patient. What I'm doing is I'm basically enrolling patients with portopulmonary hypertension. Then I'm checking their estrogen level, and then I'm checking their urine estrogen metabolite level. And I'm comparing this with those patients who do have liver cirrhosis, but they do not have portopulmonary hypertension. So just cirrhosis versus cirrhosis patients with pulmonary hypertension. So we will see what it shows, if their estrogen or urine metabolite is higher or not. And if it is, then probably are in the right direction looking for it. We actually did one more study, and this is not published, but it's accepted for presentation as a scientific abstract for this year's American Thoracic Society meeting in coming May. What we did, we used the same thought process that for some reason, estrogen levels and metabolism is more in patients who develop pulmonary hypertension in the setting of liver cirrhosis, basically in portopulmonary hypertensive patients. So what we did, we looked back at all of our portopulmonary hypertensive patients who had liver transplant at our center. So I took out their liver samples, stained it for aromatase, did an immunofluorescent staining of that. And then I took another control group, which was basically just patients with liver cirrhosis and no aromatase stain on that. And basically we tried to compare. And we actually found that there is increased aromatase staining in both the groups. It was not discriminatory that aromatase was higher in patients with PAH versus just plain simple cirrhosis, but it was definitely overexpressed in both groups. We could not discriminate between the two. The conclusions from this study is definitely aromatase is overexpressed in liver, but it was not different in the two groups, probably highlighting that either it's not playing the role with the induction in the liver, or it may be happening somewhere else. Since this study was not able to give us this answer, whether the liver is the source of increased aromatase expression, what we did, we had few patients who had died over the year, unfortunately, because of some whatever reason with portopulmonary hypertension. We took their autopsy slides from their lungs, and we did their pulmonary arterial endothelial cell for aromatase enzyme. And actually, interestingly, it was positive. So kind of gave us a clue that probably this overexpression of aromatase is not happening in liver, it's probably happening in the lung, maybe endothelial cells. So now what we are trying to do is to take these endothelial cells, and there is a special technique like you do when you're doing a right heart cath, you get their catheter tip and then you harvest the PA endothelial cells, and then you basically stain those cells for aromatase. Then we will see. We don't know as yet, but hopefully we will have an answer. That's what I would think, that why it is important to do good active research in pulmonary arterial hypertension. My name is Sandeep Sahay, and I'm aware that I'm rare.